Good evening for some of you. Thanks so much for joining. We'll get started in just a minute. If you are on, if you want to please introduce yourself in the chat, we'd love to see who's here, what brought you to the community forum today. If you've been here before, this is maybe your first one, we'd love to see who is here. So please do introduce yourself and we'll get started in just a minute. And can you guys see my screen with the title slide?
Yes.
Okay, thank you. I see some familiar names and faces. Welcome back. Thanks for joining us again. Okay, well, let's dive in. So just to start off, thank you so much for joining us for this month's Wisdom Community Forum. I'm Allison Fiscalini, and I'm the director of the Wisdom Study based at UC San Francisco. So if you haven't yet, please introduce yourself in the chat. We'd love to see who's here, where you're coming from, what brought you to the forum. And this is maybe your first one. Here are your questions. We want to see, your feedback, and we want to know sort of where there might be areas that we can explain and provide more information. The meeting is being recorded so that we can show it to people if they were not able to join. We usually post these on our Wisdom YouTube channel, so it's available to everyone. If you're not we'll ask that you mute yourself so that we can hear the speakers. But if you do have questions, we encourage you to either raise your hand or put those questions. And we will have a short feedback survey at the end. So thank you so much for joining. There's now is really to bring together our community wisdom participants, supporters, those who are interested in breast cancer research and women's health in general, and really to move together toward equity and better outcomes in breast cancer for everyone. Part of the goal of that is to really have a dialogue and a conversation on different topics in this area, and to be able to hear from more information would be helpful, but also to hear what matters most to you and how we can incorporate that better into the way in which the wisdom study is being exploration. So with that, I mentioned that we have a lot of, we've been doing this for a few years, and we have a lot of different forums that have been recorded. So you can see there's a lot of different topics that are posted on our YouTube site. There's a really rich library of videos that we'd encourage you to access. We're always happy to re-present a topic if there's new information or maybe there's different questions that are had. So please do suggest new topics. But what we'll discuss this month are wisdom, trying to give participants to understand some risk reducing recommendations that we may have. So with this, of myself, Allison, and Graham at UCSF, presenting the tool as well as answering questions. We are both at UC San Francisco and have been working together for about the last 13 or so years. And the tool that we'll discuss today is, we call it the Breast Health Decisions tool. And I'll let Laura kind of go through why the tool was developed. We can go through who has access to it now in the study and who will have access to it soon. And then we'll walk you through what the tool looks like and how you can access it if you're a participant. if you're not a participant, maybe this is a reason you might want to join so that you can see this tool and understand some additional information about your personalized risk. So Laura, I'll let you take it away and just give a little history of why this tool and this idea of explaining risk was created, and we can dive in from there.
Yeah, so thanks so much. I think one of the, I've been working on breast cancer risk reduction and prevention for 25 years. And, I think one of the critical things that we want to emphasize is, there are certain things that everybody should know to try and reduce your risk, but it is also important to sort of think about who's at particular risk and what can we do to really make a difference in dropping the incidence of breast cancer and not just screening for it and not just treating. And depending on how high your risk is, it may make sense to think about certain interventions. And that's and we're actually, working on a whole new conference called Rise Up for Breast Cancer, where we're really trying to encourage a more holistic way of thinking about things that we're already doing for women with cycle control, contraception, IVF, postpartum weaning, postmenopausal hormone management, where we want the field to be thinking more about all the things that a woman is considering and how do we do this in a way that what we do is risk reducing. And also, even for some of the interventions that we do have for cancer, how can we make these more tolerable so that people are willing and want to be on medications that help reduce their risk, rather than making them just harsh and so that people drop off and don't use them. So, this is really, if you think about it, this is very much like what cardiology did. And I've talked about this before, so just bear with me. I know this is a little repetitive, but I think it's an important analogy. When I started practicing in the late 80s, early 90s, the risk of dying of heart disease was much higher than the risk of getting breast cancer. But in fact, that risk has gone way down. And now the risk of getting cancer is higher than heart disease. And why is that? Because in 1949, with the Framingham study, which was really looking at risk factors for heart disease, they went on and systematically developed, a set of risk factors that predicted risk and some intermediate endpoints like blood pressure, cholesterol, et cetera, that were the targets for trying to reduce the risk of breast cancer. I don't know, all of you who are on a statin or have a family member on a statin, raise your hand on your, so we can just see, take something that's super common that people are used to thinking about. And because I think that's what we're trying to do, is just get people to think about the kinds of things that we are routinely already doing to think about health, right? And so I see a couple, there must be more than that. Everybody know how to raise their hand. It's in the bottom of their Zoom.
And Laura, there was one question in the chat, just a quick definition of
Sure.
what is a statin, and yeah.
Oh, sure. So
Yeah.
a statin it's like simvastatin or rovastatin or one of the drugs that we use to lower cholesterol. So the idea was that they proved that if you had a high cholesterol or you have a family history of heart disease and high cholesterol or strokes, that if you took a statin, you would reduce your chance of having a lethal event by 30%. And then it turns out another intermediate measure that increases your risk of heart disease is blood pressure and weight. And so these are all things that came together that people started working on. So now you can get blood pressure medications on that just target blood pressure. And they're fairly easy studies to do. Or new cholesterol lowering agents that just target cholesterol. But the idea is you're targeting cholesterol, you're targeting your blood pressure because you're trying to reduce the risk of having a heart attack or dying early from cardiac disease or getting a stroke. So let's put that now in perspective with breast cancer. So there's lots of things, turns out that most of the things you do to improve your health are, work to reduce your risk of other bad things, in trying to eat a healthier diet that's had lower in animal fats and higher in vegetable, and vegetables uh, and thinking about how to get more exercise. These are all things that improve your health writ large, whether it's a risk of diabetes or a risk of heart disease or a risk of cancer, colon cancer, breast cancer. These are all good, right? And obviously not smoking, these are things that you can do. So those are the things you can do. It's hard to change the age at which you had your periods once you're in your 30s. And it's hard to, have children earlier if you haven't had a child and it's in your 34, right? So it's, those are things that you don't necessarily change, and those are life, life decisions that you make that you have to make trade-offs for. But there are a number of things that can be done that we know will reduce the risk of breast cancer. And so these are things that we want to bring to people's attention in a way that's accessible and people can know about. They're not things you have to do, but they're things that you can do, just like taking a statin maybe. And so what we wanted to do was start with a tool that helped you understand what your risk is and how that compares to someone of average risk, and what that might mean at 5 years, at 10 years, or over your lifetime. So that, people may not realize that your risk for, breast cancer might be 1.5% in the next 5 years. That seems super low. But you may have factors that over your lifetime really amount to 25% chance of getting a breast cancer, when in fact the average person is more like 12%. So what we want to do is help you understand what's your risk in particular, and how does it compare to women your age. And we are not trying to target everybody. We're trying to really target the top 2.5% of women at risk. The very top people, and these are people who have 25 to 30, maybe 25 to 35% chance of getting breast cancer in lifetime, or they've inherited a specific error in the genes, like a BRCA1 gene that is mutated or doesn't do DNA, doesn't do repair when the cells are dividing, doesn't do that very well. Because those are people of risk more like 60 to 80% in their lifetime. So trying to really not overcall, but really to try and get the group of people who really do have benefit to think about it, and to think about what they can do in addition to lifestyle things, which we recommend for everybody. And of course, alcohol is another one of those things, which, trying to stick to 3 to 5 glasses of wine a week and no more. That's actually really important. That's another constant risk factor, I'm afraid to say. But fortunately, coffee is not. So you can see I have my afternoon latte. Fortunately, that is not a risk factor. But what we wanted to do is figure out a way to put this information together in a pretty easy to digest, consistent way, and to also make sure that the people who are providing that information, the family practitioners or internists, also had access to it, because they don't often know that much about breast cancer risk. So we've developed a group of people called breast health specialists who are experts in this, and who in the wisdom study actually call everyone who's got a risk that meets that threshold of top 2.5% of women for your age group. So again, we're really looking at that top group of people. And for that, there are some things that we can do right now, and new and emerging things that we hope will come into the field to improve the ways in which we think about risk reduction. There may be ways of which to reformulate birth control pills to make them risk reducing. Instead of having a period every month, to have it every 4 months. Or, there's a contraceptive called Nextellus that actually looks like it's got a SERM, a drug, a selective estrogen receptor modulator or blocker, like tamoxifen. But no one's really done some of the follow-up work, but it certainly looks like that's a drug that might do that. And again, why aren't we thinking about trying to, if someone's going to be on some kind of hormonal medication, why not make it so that it's more risk reducing? So those are the ideas, that if we can really find the people who are at risk, and we can try and look at what are things that we can do? Now, one of the standby medications that have been used to reduce breast cancer risk is tamoxifen, which really has a very bad rap, and most people don't want to take it because they don't like the way it makes them feel. But one of the really important breakthroughs, I think, is that if you give that drug in a baby dose, 5 milligrams, so a quarter of what the dose is used for people who actually have breast cancer. So what we call baby tamoxifen, it actually has way, way, way reduced side effects, and most people tolerate it very well. Now, not everybody does, but that's the one good thing about tamoxifen or any of these risk-preventing drugs. I always tell people, don't decide whether it's right for you or not until you've tried it. Try it for a month. You're not going to have anything happen that's irreversible or bad. And if it doesn't bother you and it would drop your risk in half, why would you not do it? But I always say, just try it for a month, and then let's talk about whether you want to do it. So one of the most common medications, tamoxifen, now is available to be used every other day, and people usually do really very well with it. So these are the reasons why, and the reason why we want to really look at this is that we really want to, we don't just want to screen for breast cancer, we want to reduce the chance that someone would ever get it. And, and how can we really improve and what we're trying to say is that if we had better drugs out there that were used for other things that people really tolerated, like, for example, for contraception, that actually were risk reducing for breast cancer, that more people would use it. But we have to show that that is true, so that people actually will pay attention and do the work that we need to put those kinds of agents on the market. I mean, I can ask all of you, what do you think? If you knew that there was a choice, so I think one of the things that's important is that when you're young, in your 30s and early 40s, if you take something to reduce your risk, it's the most effective time to do that because it changes the environment of the breast and can reduce your risk, continue to reduce the risk more and more over at least 10 years. So if we had something like that, would that be something that you guys would think is important for us to tell people about and have available on the market? Comments from people? Diane?
Oh, that may have been left over from the statins hand raise. I think just to point out too, Laura, that the recommendation is really just for those women who have the highest risk, that top 2.5%, not for everyone in the general population to take it.
We've incorporated this risk tool into the breast health decisions tool into Wisdom, so anybody can go in and see. We're going to show you an example, so anyone can go in and look. And if you're interested in talking about it, we're happy to talk to you about it. But in particular, we want to take the people who really have 25% or higher chance of getting breast cancer in their lifetime to see what can we do to reduce that risk, because prevention is always better than screening if you can. So that's one of the reasons why we actually, are looking and have worked to drop the risk assessment period to 30, because if you have an inherited mutation, the time to know about that is when you're in your 30s, because that's a big period of risk. A third of the cancers for women who are mutation carriers happen in their 30s. So we're missing a big opportunity. And we found that there are people who have what we call polygenic risk, or so many genes that contribute to that, that tell us that because we're trying to predict who's at risk for what kind of cancer, so we can actually predict now who's at risk for getting a hormone-positive breast cancer. So that would mean the most useful piece of information to say, oh yeah, that something like tamoxifen would be a benefit to me. And of course, you have to decide whether or not it's worth it to you, but it's always better not to get it, especially if you did a month trial and it didn't bother you. Does that make sense to people?
So Laura, I think if we walk through the tool, you can kind of see, people will be able to see how we present the information, and there might be some questions once we sort of dig in.
Exactly.
Um,
Yeah, so
so let
stop if
me,
there are any
I'll,
questions. And so,
yeah,
Allison, are you monitoring the chat?
yes, I am. Yeah. So there was a sort of unrelated question about hormone replacement therapy and tendon injury that maybe we'll save for the end. And then a couple other people commented that they thought it would be good to have the option to take tamoxifen to reduce risk if you are at high risk. So,
Right. And we know that people at average risk aren't, and they shouldn't be taking it. We don't want people to take a bunch of things that they don't need. That's
yeah,
not something that we want.
yeah. So just to navigate through, so for the wisdom study, this is what someone's study portal looks like. When you join the study and you've been in the study, you complete the steps, you have documents that you can see, your risk assessment, your screening assignment letter, your genetic report. We kind of compile all the information into one place for you. Within this is what we call the risk assessment, or the where is it on the left side, where it says new breast health decisions tool. So this is the tool that we're talking about. It's available to everyone in the personalized arm of the study if you're between 40 and 74 or 40 plus. Um, we're making the changes now to make it available to people between the ages of 30 and 39, as well as for people who have a genetic mutation. Right now, the tool's not designed for someone with a genetic mutation because those people get a detailed genetic consultation from one of our breast health specialists. But we will make changes so that that information is all incorporated into one place. Yeah, so this is what the portal looks like for someone who's joined Wisdom. If they click into the Breast Health Decisions tool, then they launch into a step-by-step walkthrough of what the risk factors are. And Laura, if you want to go through.
Sure. So here, if you want to look at your risk snapshot, here you can click on any one of those, like click on age, and it'll show you why does age matter, and that the risk of breast cancer increases with age, and most breast cancer cases are in women over the age of 50. And, each one of these is something that you can click on. So my breast biopsy history, for example, is another thing you can click on. And now this is actually very interesting, is that a lot of these studies were done, in populations even before screening, like the Gale risk showed that breast biopsies made a difference, but those were things where people had masses. So what happens is sometimes now we do biopsies because you have something abnormal on a mammogram, and that doesn't have quite as much importance. So that's one of the things that we actually take a look at. We also can look at breast density as a way to try and understand what to do. And so this actually tells you, okay, breast density is measured on a scale of 1 to 4, or actually now I think it's A to D, A, B, C, D, D being extremely dense. And this can actually be somewhat confusing, right? Because people say, oh, if you have dense breast tissue, you should get an MRI. But not necessarily, because half the women have dense breast tissue. And if you're under the age of 50, about 60% of women have dense breast tissue. But extremely dense is only 10 to 15% of women. So we think that that's more where you ought to be thinking about it. But if you have absolutely no other risk factors, that may not then rise to the threshold where you need to have it. So you're saying, well, why not do an MRI? MRIs are expensive. They come with copays that are often 20%. So you can get stuck with a, pretty big bill, several $100s, which you weren't expecting. They come with false positives and, extra biopsies and things. Then they also run the risk of finding little things like DCIS that may or may not be useful to you. So these are the reasons why we don't want to do too much, but we want to do just enough. And if you are at risk, obviously a contrast study like an MRI is better than a mammogram, and it's better than an ultrasound. Okay.
So just one note, just to be clear, that all of these fields here, so heterogeneously dense and the white 44, those are all based on your individual information. So this is a test participant, sort of an example participant. But if you were to be in the wisdom study and access it, this would all be your
Your
individual information.
Exactly. So
Yep.
scroll down here. So for example, now polygenic risk score, so the breast cancer surveillance 5-year score here, that happens to be quite high. 4.23 is quite high for somebody who's in their 40s, should be under 1.5. So that's going to be someone where it's high. And if you look at the polygenic risk score, that's over 1. So that's not super high, but it's greater than average. So it contributes to it. So in particular, if you look at your personalized risk of developing breast cancer in the next 5 years, it's 4.53. Now we're going to show you on the next page how that is in context, so put that in perspective, but it gives you what your recommendation is. And now you can see for a person just like me, that you can see that this is a 44-year-old white person of average risk would maybe have a risk of 1 in 100, whereas a person like the person whose risk we're going through is about 5 out of 100. So you're about 5 times higher than the average person's risk. So as I said, quite high. And this is over the next 5 years. And if we wanted to look at 10-year, now you can click on the 10-year and pop down. And again, you can see that it's, bigger. And now let's look at the lifetime risk. And you can see that this is where I think it gets people's attention. So I was going to guess that kind of risk would be about 45% of total lifetime risk, which is pretty high. And if you could use, especially if part of what was driving this is atypia, you can get like a 70% reduction and get this down way, way, way lower. And that would maybe motivate someone to say, wow, I could take tamoxifen if I have absolutely no side effects from it. Why would I not want to do that and bring my risk down? You don't do it lightly, but you do it if you've got a big risk. Does that make sense to people? So we're trying to help people who are at higher risk to understand that. Now, okay, so that helps you. Now you can sort of think about, well, what's my screening plan? And so here we would say, because the risk is higher, we would want someone to get a mammogram. And, it's getting to be at close to a risk where, if someone had a very dense breast tissue, her risk would be even higher, and she would probably get recommended for an MRI. But that can give you what that plan is and why. And then, but more importantly here, and this goes to the benefits and harms of screening, and you can learn more at the bottom for each one of these. It goes through that, and you can look at the harms so that people are prepared for what happens. And, and then we can learn more about why we think a more personalized approach is important. But if we want to look at risk reducing strategies, that's the next section. So we can talk about either medications or lifestyle. So because this person is 44, we would not recommend some of the aromatase inhibitors, like raloxifene, exemestane, or anastrozole, but we would recommend tamoxifen. Now, the data would suggest that you can drop that risk in half, but importantly, it can talk about what the risks and benefits are for tamoxifen, but tamoxifen can actually drop your risk of getting breast cancer by about half. And, if this person happened to have had atypia, it would drop their risk about 80%. So these are things that we actually really know. I know my experience is that people want to know if they in particular are going to benefit and if they have benefited. So one of the nice things is we can look to see if people's breast density goes down or if they're getting an MRI, whether their background enhancement on MRI goes down. These are ways in which we can know if they are making a difference. So if you look at the risks, scroll down a little bit, you can see that endometrial cancer risks, which are written about really if you go to 60 plus, and this is what and you can see this goes up if you're 60 plus, but if you are taking baby TAM, none of these vascular risks and none of the endometrial cancer risks happen. So I think that that's really important. Now, we don't know 100% how that affects the fracture risk, but taking tamoxifen actually protects your bones, right? So it not only drops your risk of DCIS and invasive cancer, it also decreases your fracture risk quite substantially. So the green is no treatment or placebo, and the blue is taking something. And we go over this just to try and give people that sense that it makes a difference. And we do know that taking a medication like tamoxifen continues to lower your risk for up to 10 years, which is really important. And if you take baby tamoxifen, which we don't have here now, but none of these risks are there. It rarely causes hot flashes. It doesn't increase your risk of endometrial cancer, and it doesn't cause blood clots, for the studies that's been done. Now, there are thousands and thousands and thousands of women who have taken tamoxifen at the 20 milligram dose and not as many who have taken it at the 5 milligram dose. But so far, it seems like baby TAM is a very good strategy. And we are trying to develop better, more holistic strategies. So we hope that soon there'll be lots of new options. Okay, so now let's just say we want to go over, say, the lifestyle issues, right? Because these are really important. And these are, these really apply to the person whose information is in here based on what they reported was their alcohol consumption. So we're recommending, that they reduce the amount of alcohol that they drink. And, a lot of people think, oh, I can have a couple glasses of wine a day and that won't affect things. But in fact, we recommend that you really try and have, if you're going to drink, if you like to have more than 1 or 2 glasses when you drink, pick one night a week to have alcohol. And otherwise, use soda water and fun juices and an umbrella to make you feel like you're drinking a cocktail, but make yourself a mocktail. But it's one of the most consistent risk factors. So these are just some strategies, what to do to lower body mass index. And everybody knows that it's important to, that weight control is important and it's good for your health, but it's also good for breast cancer risk. Interestingly, there are going to be, I am pretty certain, a number of studies that are going to be conducted to look at the type of fat you have using a DEXA scan, and that having brown fat and not white fat is important, and because of inflammatory tendencies. And so that some of the GLP-1 drugs may be used as a way to reduce breast cancer risk. And again, sort of a global health index, that it lowers your body mass index, it lowers your breast cancer index, it lowers your chance of diabetes. These are all things, especially if people aren't dependent on them and don't have to be on them for long periods of time, especially if you combine those with things like taking, eating a lot of fiber. And by the way, if there are any survivors who want to participate in our fiber study, let us, put your name in the chat, and we'll send it to Katrine Whitson. We'll send you an email to participate in this. We're looking to see whether we can help people change their diet and have more fiber, as that really changes the kind of bacteria that are in your gut, that we think that also improves your chance of surviving a long time without breast
Hey, Laura,
cancer.
real quick, before you move on, can you define brown fat and white fat and GLP-1, please?
Oh, sure. Sorry. Yeah. So it turns out that you have different kinds of fat. One is white fat, another is brown fat. And the white fat tends to have more of these macrophages or crown-like structures that cause inflammation. It's just the way it's organized. And so it's not just whether your body mass index is normal or not. It's also the the composition of your fat. So if you have fat around your abdomen, that's supposedly a little bit more of a risk factor. So the GLP-1 drugs are these things that, are incessantly being advertised on TV. Wegovy and Jardiance and blah, 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 all these other drugs, which really are um, really, what they do is they slow the way you absorb sugar. So instead of having a big spike in sugar, which kind of has this cycle of increasing sort of what you eat in this kind of addiction to salt and sweet. So one of the interesting findings is that people on these drugs have really reduced their consumption of soft drinks and fast foods and junk food, which the junk food industry is not so happy about. But they, so sometimes, there's this big dilemma, oh, people can't afford them and how terrible it is. But in fact, it may be something that if we can really get a grip on the obesity dilemma in this country, that we would dramatically improve people's health. And once people can get on a better footing, they can control their weight better and they feel better. They're more likely to get exercise because it's easier to exercise. So there's lots of this. I think the story is not written as to what to do. So there is a type of DEXA scan that you can get that tells you not just about bone density, but it tells you about the type of fat you have and the ratio of fat you have. And so these are things that, that there is, and that's, I see there's a question about, is there an intervention or exercise to increase brown fat? I don't know the answer to that, but we'll look into it. But I do know that you can, we used to say, oh, if there was a drug for that, people would be willing to do it. But it turns out, honestly, there are. And I'm not a fan of having everybody be on a drug for something. But again, it's only the people who really need it. But once you get into better balance, you can keep it that way. There's another question about fiber, and fiber, again, in particular, if you were, in the US, we tend to have 10 to 15 grams of fiber a day in our diet, when really you should be trying to get 40 grams of fiber in your diet. It really changes. Again, this is one of the things that changes the bacteria that you have in your gut, and the bacteria that have to break down fiber slow down the absorption of sugar, and that's one of the things that decreases your diabetes risk and your craving for fast foods, the same thing that drugs like Wegovy and so on do. And you're right, Maria, that stevia is one of those sweeteners that doesn't cause a spike in blood sugar. I don't know how to get the fast food industry to stop using it, because it's, they've got the right sugar salt combination to sell lots of things. But it is really interesting that these drugs, or these things that sort of keep you on better balance, really decrease your craving for fast food. Okay, so those are just some things, and the more we study this and the more we look at it, the more we can come up with better things. So exercise, obviously, you can talk about that, or if someone was a smoker, obviously the most important thing to do is to stop smoking. If you're taking combined hormone replacement to control menopausal symptoms, or to even, some people may be using them in, that's why one of the things in this meeting in the fall, Rise Up for Breast Cancer, we're trying to look at, what are the different forms of birth control that we can use that really reduce the number of cycles that you have. And, we're very lucky that birth control pills reduce the risk of ovarian cancer. and they reduce the risk of colon cancer, but they don't necessarily reduce the risk of cervical cancer, nor do they reduce the risk of breast cancer. But there probably are changes that could be made just by reducing the number of times you ovulate, that could reduce the risk. These are the kinds of things that we're trying to explore in our meeting in the fall, Rise Up for Breast Cancer, November 1 through 3, to try and get people into a more holistic view of women's health. So these are just some of the things that we have. And so this is the summary that everybody has. So it just kind of goes through each one of these things that, again, showing you your current alcohol consumption increases your risk of breast cancer. And so maintaining a weight. So these are all things that are very specific to this particular person. And that we could see that she's not exercising as much as she could. And again, I think, hey, Allison, let's get rid of the word chemo prevention, call it endocrine risk reduction. I think makes people think that it's chemotherapy, which it is not. It's just it's a hormonal drug. And again, baby tamoxifen, you can take 10 milligrams every other day. So these are all things that people can do. And it's not that you have to do it, but again, we're just trying to take the people at highest risk. And what if we could take the people at highest risk and drop that risk in half? We ought to see a reduction in the incidence of breast cancer. So what we want to do is say, what's the lowest hanging fruit, and get the people with the most risk to have the most benefit early on. And that's one of the reasons why we're trying to look early. It might be that there's a situation where you have a high lifetime risk, but it's not, the timing is not that you're going to get it in the next 5 years, but your lifetime risk is high. So if you start taking it in your late 30s, as long as you're not trying to get pregnant, that can really set you up to have your risk reduced a lot over the next 10 years, even if you take it for just 3 years. So that's the idea. So then we can give you a summary report that goes through that you can save and have just a PDF of this and give this to your primary care physician. And we're working now on how to figure out how to send it to your primary care physician. And one of the things that we found out is that, maybe about 40% of women were very interested in doing more to reduce their risk, but at the end of the day, only about 12% of people wound up taking risk-reducing medicines because they didn't have the conversation with their primary care physician, or the primary care physician didn't pay enough attention to it. So we know that part of our job is trying to make sure that this information gets to people and to their physicians in a timely way. So those are the things that we're trying to do with this whole idea of breast health decisions. And it's a framework to start with what we have that reduces risk, and hopefully help serve us as new ideas come in and we have data to show it works that we can add to it. So one of the things that I would like to get some feedback from people is, how does this kind of a tool seem to you? And what are the things that we can do to make it a little bit more appealing? And we're especially concerned that women of color are not particularly interested or convinced by this. So I think we probably have to do a little more work on sort of tailoring the message a little bit to making it more, I don't know whether it's just doesn't feel like it's applicable, or doesn't feel like it's accessible or important. So we'd like to get some feedback from all of you on this kind of an approach, and try and understand what you think, what you like about it, what you don't like about it, what you'd like to see us do differently.
It looks like Maria has her hand up, and then Carrie after.
Great, Maria.
Thank you. I just wanted to let you know I actually listening to all this and the about the different medications and stuff. And I'm kind of surprised that everybody was all concerned about my risk for cancer when I was younger at 40. And none of the physicians I've had at the VA had ever suggested tamoxifen until I joined this study. So now I'm going to have that discussion with my doctor. But I'm realizing that there are many things that can also affect, you know, so I had put that question in the chat. It so it's just something, it's called tendinopathy, and it's caused by lower estrogen levels. So if you're not able to take HRT, I mean, there's exercise and stuff like that, but I was just curious to know if there was anything else that could be done.
So tendinopathy?
Tendinopathy, yeah.
Oh,
I've
because of tendon.
I've never had any serious injuries or anything until after menopause, where I've had physical therapy twice for my tendons.
Mm-hmm.
And I just recently started doing some research on it, and to see what I could do. And exercise seems to be like one of the number one things. But like
Yes.
for this, it's more specific type of exercises.
Right, so the tendinopathy, again, that's like a lot of times if you go to a physical therapist, they'll have special thing, and because just exercising and pushing through the pain can sometimes make it worse.
Right.
So it's actually important to try and figure out the things that actually help you as opposed to aggravate it, right?
Yeah, and the one example I wanted to share is how many people's feet toes point up after they've worn high heels.
Uh,
If you have that, that's that tendinopathy starting to have an effect on the tendons in your feet. I mean, I'm having issue. I never had these issues before, but like I said, doing some research, um, um, it just kind of got my attention. So,
So the first comment that you made though about tamoxifen, just to make a quick comment on that, I think some of the information presented with the baby tamoxifen, the lower dose tamoxifen, is pretty, I would say, new recent data in the last few years. And so hopefully that will help bring this as a more tolerable option for people. As Laura mentioned, not everyone can tolerate it well, but in the lower doses, it's much more tolerable. So
really
hopefully,
very well tolerated, and there's good data, long now 10-year follow-up data, that again, just like the 20 milligram dose, you tend to get this benefit that it continues to increase. But and you can understand, I think a lot of the times the drugs, when they're developed, they are developed at the maximum tolerated dose, and it's just a change in the strategy. And it's super important because it can take something that is, could be very effective and easy to use to reduce risk. And, that's, so we're interested in that, and obviously interested in things that people can do. One of the things that may really reduce the risk of fast-growing tumors or hormone-positive growing tumors, um, uh, that fiber can be a really important adjunct. And, you know, we can actually put in a page. It's a good idea. Someone suggested putting in a page about fiber. I mean, there's lots of things, like an avocado has 10 grams of fiber. A box of raspberries has 8 grams of fiber. Chia seeds are fairly cheap and they're easy to use, and they actually provide a lot of fiber. Yeah, so these are things that we can put in as suggestions that people can have. You just get in the habit of sprinkling chia seeds in your food. Uh, Hazel, you asked if we've tested the readability of the tool. Yeah, we made it for 8th grade readability. So that was really one of the things that we developed for that. And
Some of the
yeah,
some of the new information, I think we can revisit too, because I think we've added more that we'll want to make sure not just goes through the standard readability assessment, but also like, gets tested for comprehension.
it's
I
good. We
think
can
that's
ask,
important.
yeah, we can ask Linda Newhouser to help us with some of that, maybe. She has a
Yeah.
group in Berkeley that can do some of that for us.
Yeah.
I
Yeah.
think
It's
that's a good
really,
idea.
it's a great point. Thank
Yeah, and
you.
we should
Yeah.
definitely put in, we can put in a picture, a page on fiber, right? Actually, we can use some of Katrine's slides, but some of the things that, we know are fairly easy and accessible. And look for cheap ways to improve fiber.
One other
But perhaps
suggestion
you
that
should work with perhaps you should work with your, partners here to figure out, like, I mean, chia seeds, that's not for everybody. Honestly, I don't think everybody knows what chia seeds are, has had that experience, but maybe if, any of the things that are like, you could add this or do that or eat this or eat that, get those like in a very kind of a hyper local way, so that it
For different,
resonates. Like when people see those as recommendations, they resonate with them. They're not like, what are chia seeds, and then have to go look them up.
right, or you could say, so that's a good idea. So just thinking about what are more typical things in an Asian diet, or people who are African American, or people who are Latina, and you could sort of have them, that there are different fiber choices. I mean, truly any fruit or vegetable that has any kind of fiber in it I mean, that's, I mean, there are a lot of things that have fiber. You can look them up, sweet
we can,
potatoes, various things. But we can put something like that together. I think that would be good.
yeah,
But I also think,
Katrina has a lot of that as resources and visuals too, really good visuals to show pictures of things as well. So we can pull that into the information we have too. Yeah. I want to make
yeah,
sure
and
we
I
get to
think that's
Carrie's.
important. Maria said that the people who are juicing, in fact, all that stuff you take out, like carrots and all that stuff, that's the fiber. You don't want to take out the fiber. Even in a grapefruit, you don't want to take out the fiber. You want to eat the stuff that's the fiber.
I want to make sure we get to Carrie's question.
Okay, great. Carrie?
Yeah, I'm very glad to hear that you're concerned about getting this information or appealing to more women of color, particularly Black women who have more adverse reactions to breast cancer. But I wonder, are you reaching out to Black women's health groups to talk about this information? Because unfortunately, historically, the healthcare industry has a really bad name within the Black community. So I'm skeptical that just, throwing information out is going to be helpful. Who among you is doing the research to actually dig deeper into the Black community to get this information out there and to become a partner with them, not just send information unilaterally, but then get input from them into these issues?
So with Kim Rhodes, which I think now we've updated the tool, it would be good for us. We have lots of different community groups who are advisors to us that we should go through the information with and get their feedback about what they like and they don't like. The other thing that we are working on there's a number of groups around the country that are specifically trying to, there's 3 or 4 big cohorts of trying to understand risk in Black women. There's the Voices, which is the American Cancer Society. Melissa Davis has the Sambai Project. There's a whole bunch of, Scarlett Gomez has one for Asian American women. And I think what we want to do is try and, sync up and help. There's so much work to do, we don't need to duplicate. But one of the ideas I had was that we have someone who's specifically who's Asian American, who has an Asian background, can counsel people of Asian backgrounds. That's not necessarily absolutely essential, but I think sometimes, I don't know whether we should ask if you want someone I'm requesting someone who looks more like me, but like between all of us around who have coordinators who are, either Latina or African American or, um, you know, Asian or whatever, that sometimes people like to hear information from someone who looks more like them. And there's enough groups of people who are doing some of this work that we can have, a pool of people who can do the counseling that would make it more appropriate. I've been keeping an eye on this so that I think it's easier or more likely that someone who is white, I think, is more used to hearing some of this information, and it's sort of a little bit more in the culture used to seeing it. And I'm just even looking to see what percentage of people pick up the phone and agree to have the high-risk counseling session. And the African American patients at high risk, it's only 50%. So I'm unhappy about that. That's not good enough. So we need to make a change, right? So, and that's just data we just got in. I mean, that happened at the beginning of the study, but of course we knew that because we didn't have enough, or because our diversity in enrollment was poor. But now that our diversity is much better, it's still not enough. That's still not good enough. So one of the ideas is, but so then one of the questions is, do you necessarily just assign people? You don't always know, right? But you can even ask people, I'm interested in talking to anyone. I'd be more interested in talking to someone who is Asian or Latino or African American, or we could ask people who they might be interested in talking to. These are some of the things that we can do.
I want to make sure Hazel gets a chance. She has put some really great comments in the chat, but also has her hand up. So Hazel, do you want to ask your question?
Sure. I'm not sure if Patrina was before me, though. Was Patrina before me? I think she was.
No,
and
I think your hand, I don't know if your hand was up first.
Oh, okay. So
I can wait.
Oh, thank you. Thank you so
No
much,
worries.
Allison, because I put a couple of contacts. So I'm just thinking what Carrie brought up was very important in terms of level of distrust amongst African American and thinking Latino, but particularly African Americans, given our history in this country. I'm just thinking about my recent, and I'm educated, middle income, and I really had a lot of hesitation about the vaccine. However, by my attending virtual community forums offered through Charles Drew University of Medicine and Science, where I knew there were reputable African-American health professionals, physicians, who were talking about it, it decreased my apprehension, and I was more, that's just an example. I was more open to getting the vaccine, but it's really important, no matter what is done, that there's culturally congruent terminology that's used, and just the way it's presented. So because I think it's not going to be as easy reaching us, given just the systematic mistreatment. I just think of so many people I know of color, particularly African Americans, who've been mistreated by healthcare providers. There's this bias against us, that it's a lot of personal blaming. So whatever can be done to minimize that would be really great. So if Allison wants to call me or to email me, and we can exchange phone numbers, because I think this is really important and I appreciate it. And there are also some providers I know who actually are reaching out to Black women in the Southern California area and have support groups. And I think you may know Pastor Rhonda, who has Shepherd's Manor. So it's a hangout for anyone, or she's welcomed her home to drop in. She does education about breast cancer or any type of cancer. So she has a high level of trust in the community. This is just one example. So thanks.
Wonderful. Thank you, Hazel. And I see your email and your note in the comments, so I will definitely reach out to you. Thank you.
Yeah, and Kim, Kim, you might want to comment, but we are, it's not just a one-time thing. It's something we have to keep doing continuously, right?
Yep. Yeah, our strategy, we call it year-round non-transactional community engagement. So we're not just here because we have a study, we're here because we're here. So if you need something, even if we can't specifically service that, then we're reaching into our institution where there are a lot of resources to try to service that. I think that the challenge is, what you brought up about discrimination, and I'm just going to call it frankly racism. And I don't know if you're all aware of the California Healthcare Foundation listening to Black voices, 3,000 Black patients talking about feeling like they needed to dress up to go to the doctor, making sure they didn't make eye contact, doing all kinds of flipping and flopping to be accepted and to not be judged. I think that's really the thing that's standing in the way of a lot of this work, because that's not trained in medical school, and cultural competence really isn't the way forward, because it's really about the capacity to see yourself as part of the community. And so that the person who's sitting in front of you, if they're not the same color as you, is not other automatically. And so the foundation is otherization, is seeing like, you're different than me, you've made bad decisions, that's why you have this disease, I'm the doctor, I'm never sick, blah, blah, blah. That's not taught. We don't teach that. So I don't know if we can fix that part, but we do need to come up with strategies that include credible messengers, which is what I think you're describing, in having people who already have a relationship, right? If we don't, I say trust builds at the pace of the relationship. So if you don't have a relationship, you shouldn't expect to have any trust. But when people know each other, there's trust already there. So I think we need to connect with the credible messengers.
So when so one of the things that we're trying to think about just going forward is also when we identify people at higher risk. And of course, now there is Fumi Olapade, and her team does have a polygenic risk that really, I think, is predictive of higher risk in African-American women. We're trying to figure out if that's hormone negative, whatever there. I mean, I think the easiest thing to do is to increase fiber content, right? Because it improves your immunity. It's like, that's just like a no-brainer. But okay, so even if we reach out, I mean, that's what these forums, of course, are all about. But you have somebody, we can invite them to be part of the forum. Maybe that's another way to say, like, we talk about these things all the time, come join our forum. But even if we have someone, and even if we have a breast health specialist that really is reaching out, that looks like whatever it is, okay, we've really got, like, do you have a healthcare provider that you trust? Can we, and if they do, great, we can make contact with that person to tell them. If they don't, but I think it's not enough just for us to talk to them and say, go talk to your doctor. I think we have to say, here's this, we think this is important, and we're going to reach out to your healthcare provider, tell us who you choose. And that I'm putting resource into that, because I think without that, nothing much is gonna happen. And that's true for white women too, by the way.
I want to make sure we get to Petrina. I think
Yeah.
that's how you pronounce your name. Is that how you pronounce it? Yeah.
Yes, Petrina. I think Dr. Kim probably summarized it about the trusted messengers. I want to say I'm in Oakland, California, and I'm the president of a sorority, Delta Sigma Theta sorority, which has 1,000 chapters, nationally and internationally, and you have to get to those trusted messengers. We have a partnership with the CDC and NCNW that has addressed getting COVID and vaccination education to the community. And I know our international president has kind of talked about the need for Black people to be in studies, right? So that we can get this information so that, the results kind of inform kind of what we're going through, right? And so getting that out there. So I'm willing to, try to make some connections. One of our national initiatives is the improved physical and mental health of Black women and girls. So I know in our chapter, as we plan for next year, I think the fiber thing is something I can bring to my, healthy lifestyles committee to say, this is something we can do. And Kim, I don't know, are you with Emoja Health?
Yes.
Yeah,
I've seen your name before. So you've seen yourself.
Yeah, I was just saying, I was actually just sending you a message to see if you wanted to get on the Emoja Health meetings. I'm the founder of Emoja Health. And actually, I think one of our advocates suggested that Wisdom do this forum to effectively kind of serve as like that kind of platform where people's voices can be heard, information can be shared, networking can happen on the back end because there are people in this meeting from all over the country. So yeah, please join us at Umoja Health since you're in Oakland. We're doing COVID, cancer, and chronic disease. And Michelle Mosley is our community health educator, and she's a Delta as well.
And
okay,
you know,
so
we
well,
would be, I
maybe
would
she
love-
can bring it to our national leadership as well, because then there are initiatives that come down to the local chapters to support and do. And then Allen Temple Health Fair is July 13th, if you're going to be there. So,
and we will be there.
Sorry, Laura.
And
Okay.
is Wisdom I think Wisdom may have a piece of our table.
That would be great.
Okay.
And
I'll
we're
double
happy to
check.
come out. We'll come out. We'll make sure that we're out, and part of that, I'll put that in my calendar. And Patrina, if there's something that you want us to come and talk about Wisdom, you know, I'll come out with Cheryl Ewing, who's my partner. She's a breast surgeon at UCSF with me. She's African American. She's, again, I think it's important that you hear from trusted messengers and people, who are really interested. We're very interested in making sure that everybody, from every race and ethnicity, has access to the trial, has access to the resources we're building, and that we don't wind up building something that's for white women and not for Asian Americans and Latin Americans and African Americans. And it's been a hugely important. And the thing is that, we all can learn from each other because we all have slightly different risks, and, you can, it's all good and all of this, but it's not good if only one group is really benefiting. So if there is anything you want us to speak at or anything that you want us to come to, we'll make ourselves available 100%.
Will do. Okay, thank you.
And that goes for everyone on the call. Just to wrap up and say thank you so much for your engagement today. And if you do think of ways in which we can come to your community and share information, engage with the community, hear from what matters most from your communities, we're happy to do so. And we have lots of materials that we already have developed, but again, everything can be changed and adapted, and would love to hear what you like and don't like, and how we can adjust things to make it resonate better.
I think it's time for us, Kim, maybe this is a good time to have another call with our community leaders and see what they think,
We did present this to the Community Leadership Board last month, our Breast Health Decisions tool, and we have our monthly meetings, but I think we can do a deeper dive out, engage the organizations that our Community Leadership Board members represent and other community members as well. So yeah. So thank you so much, everyone. I know this has been a great discussion. We are over time. But next month, we do plan to have our next forum, which will be from Dr. Vignesh Arasu, who's at Kaiser Northern California, and he is a radiologist, and a lot of his research focuses on AI and breast cancer and risk prediction and risk models and the role of AI in imaging. So
what's the hidden information in a mammogram that can tell us more about your risk?
Yeah,
that's exciting.
Our forums are the last Monday of every month. So next month will be July 29th from 4 to 5 p.m. Pacific time. And by registering for this forum, you're automatically registered for all future forums. So be on the lookout for those reminder emails. And we are so grateful for you being here today.
And thanks for all your great feedback. Thanks so much, everybody.
All right. And if you do see there was a link to a survey, we'll send it out as well. But if you do have feedback on this or other topics, or if you want more information to help share, please do let us know.
Great.
Thank you so much, everyone.
Thanks.
Bye.